We can always learn a lot from clinical trials, and I'd like to talk about two very recent ones that were published in 2021. The first is the phase III OPTIMUM trial that led to approval of our most recent disease-modifying therapy, ponesimod. This is a second-generation S1P receptor modulator, a second-generation fingolimod. This trial entered over 1,100 relapsing patients. They were randomized to two arms, either oral ponesimod 20 milligrams daily or oral teriflunomide 14 milligrams daily. The study ran 108 weeks. Its primary outcome was annualized relapse rate, and that was significantly less by 30.5% in the ponesimod arm compared to the teriflunomide arm. But I'm really mentioning it because they had the courage to add a secondary outcome that evaluated fatigue, one of the major invisible symptoms that we've been talking about. And indeed, at the end of the study, with a patient-reported outcome to look at fatigue, they showed a significant difference in that PRO rated fatigue in favor of the ponesimod arm versus the teriflunomide arm. At the end of the year, fatigue had remained stable with the ponesimod, and it had increased with the teriflunomide. Now, unfortunately, this never got to the label, and I think that was because the FDA didn't feel confident with one single patient-reported outcome that you would really say this disease-modifying therapy helps fatigue. But I think it really encourages symptoms to be looked at more with regard to secondary outcomes. The second trial I want to mention that was published was TRIUMPHANT-MS. This was a small phase III. It only entered 141 MS individuals that had significant fatigue on the Modified Fatigue Impact Scale, the MFIS. They scored greater than 33 points. This trial examined our three leading oral agents to treat fatigue in MS. So they had an amantadine arm, 100 milligrams twice a day. They had a methylphenidate arm, 10 milligrams twice a day. They had a modafinil arm, 100 milligrams twice a day. And they had a placebo arm. So they configured it that patients were randomized for up to 6 weeks to one of those four treatments, including placebo, would then get a 2-week washout and then go into the next drug or placebo treatment. And the primary outcome was the Modified Fatigue Impact Scale, the MFIS score, 5 weeks into the treatment. Lo and behold, everybody improved somewhat, even the placebo arm. There was no significant difference between the three leading oral agents to treat fatigue and the placebo arm. You could not show an improvement in fatigue. Now, in a post hoc analysis, which doesn't count, in those that had increased daytime drowsiness or sleepiness, there was a fatigue impact of methylphenidate and modafinil, but post hoc analyses don't ever count. So what would you conclude from this study? Well, I would say that our oral treatments for fatigue are not slam dunks, for sure. It could not show a benefit here, and you saw a potent placebo effect on fatigue. This doesn't mean that we shouldn't use them. I think we've all experienced patients that can respond to these treatments, but it really underwhelms for the current pharmacological approach to treat fatigue in MS, and really emphasizes the importance of other things, including perhaps cognitive behavioral therapy that can help fatigue among other symptoms. We haven't mentioned that yet. So I think there are take-home lessons from these two trials published in the last year that address different aspects of fatigue. So in our closing minutes here, I'll ask Pat and then turn to Tom. What final words would you like to say, or what important take-home for our audience would you have, Pat?
So I think it's very interesting that with the ponesimod study that it actually showed a benefit on fatigue. Traditionally, our DMTs have not shown any benefit on symptom management. However, this is interesting that it showed a benefit for fatigue, and this is really going to be an impact for our patients moving forward. With regards to the TRIUMPHANT trial, the fatigue trial, I think this brings home the issue that fatigue and the management of fatigue is really multidimensional, and it really requires a multidisciplinary approach, maybe not only pharmacological, but psychological, perhaps getting physical physical exercise, perhaps treating cognitive dysfunction and quality of life and psychosocial aspects of it.
I'm very interested to hear about the ponesimod trial and what you just said about the oral agents and their failure to modify fatigue in the other study. It doesn't surprise me a lot. It just, again, it brings us back to the issue of hard to quantify but essential physical and psychosocial sort of adaptation modifications for someone like you, Lillian, given what you've been through and how well you are working to adapt to the condition.
So I hope this has been a valuable discussion about MS symptoms and particularly invisible symptoms. We've had a wonderful multidisciplinary panel. We've heard from myself as a neurologist treating MS, from Lillian, a person living with MS, from Pat Melville, a nurse practitioner who takes care of MS, from our neuropsychologist, Tom Preston, who evaluates our MS patient. I want to thank this wonderful panel. It was truly a multidisciplinary approach, and I hope our audience enjoyed this multifaceted discussion very much. Thank you.